to go.
Welcome to the AGM, with introductions from the Interim Group Chair, Mark Friend.
Afternoon, everybody. Thank you so much for coming. This is the annual general meeting for the Norwich and Norfolk. I just want to introduce myself. I'm an Interim Group Chair, which means I've been chairing since April the NNN and the James Paget and the QEH, working with colleagues across the group. And our purpose in the group is to make sure that we can see the opportunities and seize the opportunities that are ahead of us and make good decisions together. I think it's about the making decisions together that's the key. We want to be excellent, and we think we're better off doing that together than alone. This is a hybrid event, so welcome to all those online. And the AGM is an opportunity, I think, for us to be held to account, but it's also an opportunity for us to celebrate some of the fantastic work going on within the hospital. And I just want to say a huge thank you to all the staff. You're going to see two really interesting and important developments, one around virtual wards and one around women with severe nausea during pregnancy. Those signal both the research excellence within the organisation, our active working with partners in community health and GPs and others and voluntary groups. And that is incredibly important for how we're going to develop as a group. I would like to extend a welcome to the County Council Chair, Tom Fitzpatrick. Thank you for joining us, Tom. And the Deputy Lord Mayor, James Wright. So there is an agenda, I think. Was there an agenda going to appear? No agenda. So I'd also like to say a huge thank you to our executive colleagues. It's an interesting time, I think, within the NHS, and you would have seen a lot of the public statements. Both the executives and the non-executives have remained really focused around patient safety and the quality of care we deliver. And in the 6 months as interim chair, I've had the opportunity to visit lots of the teams within the organisation, within the NNN, and I am blown away by the ambition and the care and attention being paid. A lot of the work you're going to see today, and particularly the accounts, the accounting year, was under the chairmanship of Tom Spink. And Tom, thank you very much for your dedication, your hard work over the years at NNN. I'd also like to thank our governors. The governors at NNN are incredibly active. They work really hard to hear the voice of patients, to hear the voice of staff, and to feed that through to the board, and an incredibly important part of what we do at the NNN. Thank you in particular to Elaine Bailey, who is the lead governor, but actually to all the governors. You put in a huge amount of effort. It's a voluntary role, an incredibly important one, so thank you. I'm going to pass, without further ado, to our Group Chief Executive, Lesley Dwyer, who will take us through the year.
Thank you. Whoever follows me, be careful, okay? Shorter than most. Thank you, Mark. And everyone, welcome to our annual general meeting. It is really great to see so many people here, but even more so to have spent some time with the people who really make what we do happen, and that's our staff. And you can see that for some people, it's the people who support us to be our best as well. As well as Mark's acknowledgement, I really do appreciate Tom Fitzpatrick and James Wright for joining us, but we've also got, and I just can't see them for the moment, but we've also got, there they are, two councillors, Councillor Taylors. Samantha Taylor is the chair of the Bleakley Council, and we have a younger Councillor Taylor as well. So thank you so much for coming, because this hospital doesn't exist for us, it exists because of where we are. This is actually my third AGM. I attended as a visitor the night before I was interviewed for my job. gave me some insights. Then as the Chief Executive, and now as the Group Chief Executive of our hospital group. Behind me, you're going to start to see some slides rolling, and I don't know that I'm timed to finish when they stop. So if you see them twice, just think that's great. If you see them a third time, tell me to stop, okay? But a lot has actually happened since the financial year ended. The government's 10-year plan has been published, which includes those pillars and those big shifts that we're expected to take, shifting care much closer to where people live into the community, to focus more on prevention, to make sure that we modernise what we do, to make sure we become digitally active and make it much easier for people to connect. That will bring changes to us, both as organisations but also as citizens as well. But what we need to do is make sure that those changes deliver better care when people need it most. We will continue to progress with the formation of the group, and as Mark said, that is because we've said that together we can make some bigger decisions, to do a bit of heavy lifting on behalf of each other as well, and really make sure that everything that we do is about improving the health of our community, of which we are all part of as well. It would be remiss of me before I do this just to acknowledge that many of you will have seen our performance rankings over the last couple of weeks. As I keep saying, you know, that's a wake-up call in some areas for us, an area to focus a little bit more on, but they don't define what we do next does. And following what I have to say about what we have been doing, we'll have a couple of presentations that will show really what does define us, and it's about amazing people who are really thinking deeply about the services that they provide and therefore delivering amazing care. So as this goes through, I'm not going to wait until I'm in the right spot. I just want to highlight a few key things from our review. As I've said at the two other annual meetings, I felt a bit fraudulent that I was presenting this on behalf of others that had been there longer than I had. It's lovely to be here presenting something that I was part of and continue to be part of. So around our estates and infrastructure development, we've actually delivered a $70 million capital program, which saw the new orthopaedic centre and the community diagnostic centre opened. Our radiotherapy teams have introduced surface-guided radiotherapy equipment in all 5 of our linear accelerators for quick and accurate patient positioning during cancer treatment. I've been down and had a look at that, and it's absolutely amazing, the accuracy. It's almost pinpoint accuracy. Sundri Ampi, one of our presenters today, has led a respiratory clinic at Interim, which was a success with patients seen in those community clinics, and will be something we will continue to explore. This is very much about one of those shifts. How do we move expert care closer to where people live? Last week, and I'm not stealing their thunder, our maternity and virtual ward teams were winners in the HSJ Awards for their work on caring for patients with hyperemesis gravidarum. You'll hear more about this today, and it's absolutely amazing. We've actually done lots of things that we would say were innovative, and the NNN's really known for that. What we're not so good at is telling people about it. But we've achieved the first in the region specialised cornea transplants to restore sight, and I hope you did see the story of that lovely man, because this is just so life-changing. We took part in the world first to develop a personalised vaccine against the deadliest form of skin cancer. We also became one of 5 trusts nationally to offer robotic-assisted esophagectomy. That's removing part of the esophagus and the top part of the stomach. We've also, again, going out into the community, setting up a new heart failure clinic at Cromer Hospital. We take part in groundbreaking breast cancer treatment programs where we actually are having patients who are having their DNA read like a barcode to improve treatments that are absolutely specific to them. We made some major changes to the way we organised ourselves towards the end of the year, and we created care groups that have replaced what had been our divisional structure. And the aim of those was to bring decision-making much closer to where patient care is delivered. That removes some layers of unnecessary, I think, just permission-giving, and we want to really put the hands of making decisions that is best for patients, with patients much closer to those providing the care. We did open a new and modern mess for resident doctors, not too far away from here, providing a dedicated space for study and breaks. I'm hoping it doesn't live up to its name, because often they do, but it is a really lovely place where people can take the breaks that they require. I'd be remiss for not acknowledging our volunteers, because we can't do what we do without them. We're supported by over 500 volunteers across 5 sites, including roles such as the butterfly volunteers who support patients at the end of life. I've actually shadowed a butterfly volunteer, and I can speak firsthand. It was one of the most, I think, profound experiences I've had, so privileged to be able to give that level of support. We have settle-in volunteers who meet patients as they return home, volunteer drivers who cover more miles than I think I would care to really consider. We have welfare and safety netting calls post-patient discharge. They're getting a wealth of information that really we should be taking much more notice of, but usually it is very good, and quite surprised that someone's going to give them a call. And of course our pets as therapy dogs and their owners continue to really be part of our team. And this year we started a new volunteer project which is helping prevent non-attendance for outpatient diagnostic appointments, giving people a call just to remind them that they've got that. I also do need to acknowledge something that is so important to us, which is our Norfolk and Norwich Hospitals charity. Their contributions really enable us to do those things that we would really struggle to be able to afford to do. So I do want to thank them for all of the support that they've had, and we look forward to celebrating their charity champions at the annual Staff Awards in November. The charity actually granted $1.6 million to fund additional scanners and imaging equipment at the Trust's new Community Diagnostic Centre, and $2 million to fund equipment throughout the new Norfolk and Norwich Orthopaedic Centre, known as NNUH 1. The last 5 years, the NNN Hospitals charity has awarded grants totalling more than £3 million to support the care of patients at Cromer and District Hospital. And it's opened its 3rd charity cafe, very good coffee, at the Community Diagnostic Centre, just to help generate additional stable income streams, but to make sure that people who do have to wait, because sometimes you have to wait for the second part of the procedure, are able to have something, or at least their family are. So in closing, I just want to say, as Mark did, these are interesting times, but they don't need to be times that stop us doing what we have a great ambition to do. And this will really be important that we take the most of opportunities. I also want to thank the board of the NNN, not quite as close to it as I had been since I moved into the group, but particularly to acknowledge Tom. I wouldn't be here if it wasn't for Tom's bravery in saying, I'll take somebody that we don't know from Australia, and being really, I think, ambitious for the NNN to be able to get somebody with international experience. So thank you very much for that, Tom. I also want to thank the NEDs. They've provided challenge and support and occasionally push, but also to the governors, because they are our real connection through to our public. They have been steadfast in only wanting what is best for the NNN and therefore for our patients. So thank you very much to the governors of the NNN. But in closing, most of all, I actually want to thank my colleagues. My colleagues include the leadership team of the NNN and now of the group, but particularly those colleagues that actually provide the care every day, because we're all colleagues. You're going to now hear some amazing stories of just how wonderful some of these innovations are, the thought that goes behind them, but the expertise and care that actually delivers them. So thank you very much.
Our first clinical presentation, Bringing Hospital Home, the Power of the Virtual Wards, from Virtual Ward Manager Claire Beard and Respiratory Consultants Dr. Sundari Ampikaipakan and Dr. Mark Pasteur.
Good, shall we? Fine. You going this way?
Yep. 1, 2, 3.
Right. And moving slides forward, how are we doing that? Is that this one? Yeah.
There we go.
Right. Good afternoon. I'd like to thank Mr. Friend and the Trust Board for inviting us to come and talk to you this afternoon about our experiences setting up and running the virtual ward at this hospital. My name is Dr. Mark Pasteur. I'm a respiratory consultant here, and the medical lead for the virtual ward. And I'm here with my colleagues Claire Beard, who's our nurse ward manager, and Dr. Sundari MP, who's one of my respiratory medicine colleagues, but also a virtual ward clinical champion. So we're going to talk to you about the journey from start to where we are and where we're heading. We got going in the middle of the COVID, well, at the start of the COVID pandemic, really, using government funding to set up what was in fact the first virtual ward in the country. And although born out of dark times, we've gone on to evolve to be a part of the embedded structure of the hospital and the way we look after patients. We now have a ward which has around 60 or so patients in it at any one time, and patients are at home. They are monitored with home monitoring, nursing observations, and interface with us via tablets and computers to stay in touch. When COVID settled down, we realised that having set up the ward, it offered the opportunity to evolve and change into something new, and we've extended the patient groups we see on the ward and look after. And this has been particularly stimulated by the ever-increasing demand for hospital services, ED attendances, and the need to look after older, frailer people, while at the same time minimising the amount of time they have to spend in this building having care. What do we do on the virtual ward? Well, it is a 24-hour virtual ward staffed by nurses throughout the 24-hour period, and we consult with our patients every day. Nurses and doctors do telephone or video consultations, and we are supported by a whole team of all the sort of people you'd expect to find on a medical ward: nurses, pharmacists, ward clerks, doctors, and we have networks of other hospital members who come and interface with us on the ward, and we have strong links with the community teams as well now. We do a daily ward round and aim to keep patient throughput going as well as we can to make best use of the resources. These are some of the clinical pathways we have. As you can see, our patients generally come from the medicine specialties, things like respiratory medicine, cardiology, neurology and stroke medicine, surgical specialties as well, and you're going to hear later on about some of the innovations in the gynecology sphere, particularly for pregnant women with severe nausea and vomiting. In medicine, our very highly used pathways have included looking after patients recovering from acute respiratory illnesses, COVID, flu, chest infections, pneumonia, often needing temporary use of oxygen in the home, which we supply, perhaps intravenous antibiotics, perhaps nebulized drugs. Our cardiologists have been very active in allowing patients to leave hospital quicker than planned for management of heart failure, and rather than waiting on the wards to have an operation at Prattworth, often for many weeks, they now wait at home. They remain conditioned and fit, and morale stays as high as it can do compared to what used to happen. I really would like to highlight probably one of the most successful medical wards we've had, and thank the commitment of the whole stroke management team who, to a consultant, junior doctor and specialist nurse, have all become actively involved in the service, and it's one of the smoothest running, and I think probably for the patients, one of the most useful wards we run, and keeps people at home while they wait for stroke investigations. So here we are. I will hand over to Claire, who will take it.
Thank you. This photograph was taken in April this year when we celebrated giving back the hospital 50,000 beds. Last week we hit 60,000 bed days saved, or bed days given back to the hospital. So it kind of shows how quickly we're evolving, how quickly we're moving. From my point of view, I can see that there's 3 different stakeholders in any virtual ward, and this kind of shows 2 of them. The staff, they absolutely love it on the virtual ward. It's a completely different way of working, it's a different way of looking after their patients, it's very holistic. But more importantly, particularly during COVID when we first started, and one of the reasons we were able to go 24 hours straight away was because we were able to look at staff that were shielding, staff that are unable to physically work on a physical ward, but have an amazing amount of knowledge, experience. We were able to make use of that and get them really involved in patient care, which is what they came into nursing for. The 50,000, or now the 60,000 bed days saved, that's our other biggest stakeholder, is you guys, it's the trust. We're able to help the trust get flow through, which means less ambulances standing outside, getting patients home, all those kind of things. And it also, we cost a third of a physical bed. The third stakeholder is the patient and the patient's family. What does it mean to them to be at home? Well, it's really, really stressful having a relative in hospital. It's really stressful being in hospital. We all spend our lives in hospital, but most people don't. Decreasing their hospital stay means an awful lot to most of our patients. As soon as they walk through the door, they start to decondition, they start to lose muscle mass, they're not walking as much, they're not moving as much. That puts them in at risk of hospital thrombosis. This place is full of sick people. You don't really want to be hanging out here. There's lots of infections here, so there's lots of reasons why you're better off at home. You're always going to sleep better in your own bed. You're going to eat better. You're going to get a cup of tea when you want a cup of tea, and not just when the trolley is able to get round. So, from a patient perspective, it's amazing. We get some great feedback from our patients. We also get lots of other feedback from other places. Now, you will notice that some of these are a little bit old. That is not our current Secretary of State, but it's really important to say that he actually singled out the Norfolk and Norwich Virtual Ward as the leading virtual ward in the country. And that is kind of what we are. We are the groundbreakers for this. Now, Lesley's already told you about this. I'm going to tell you again about it, and you're going to hear again about it in a little while. We have won several awards. We've won financial awards, we've won, within the hospital we've won a couple of awards. At the HSJ we've already been highly commended a few years ago. But out of over 500 projects that were put forward, only 20 people walked away with one of these last week, or 20 teams rather. So we're really proud of the fact that we've walked away with it. So we are going to keep banging on about it.
So, ladies and gentlemen, what does this all mean? The Norfolk and Norwich, we've had 4 wonderful years of experience with the virtual ward. And as far as this team is concerned, and all of us who work together, we have a vision for the future. We want to redefine what it means to be a hospital. And we think we can have a hospital without walls, a connected ecosystem of virtual care, integrated systems. There won't be a postcode lottery. It'll be easy access to everyone. There's equity, and which is so important in the geographical diversity that we have in Norfolk. This is what we envision. We envision a single point of access, which will have 3 pathways in. Currently, we step down from the acute wards. What we're hoping to see is a step up from the community and general practice and emergency admission avoidance pathways as well. This will all come into a single point of access, and they will then have a monitoring hub which will monitor these patients remotely. And this sort of Norfolk and Waveney virtual hospital, as we'd like to call it, will be built from the 3 acute hospitals in the region and the 2 community hospitals. If we come together, the future is looking bright, because we need to meet the biggest challenge of the future, a sustainable healthcare model to tackle an aging population, and also allowing our patients who are elderly, who are in care homes, to have the same access to specialist care that everyone who can walk into a hospital can have. So what this will mean is equity of access. We will need to redesign patient pathways. There's so much medical assistive technology evolving on a day-to-day basis. And it is that fundamental access to specialist services from the comfort of your own home. So I give to you that in the future, and you've heard it here first, the future begins now. The Norfolk and Norwich University Hospital will create the 4th hospital in Norfolk. Thank you. Any questions?
I have one. I'm a little bit puzzled how it actually works in practice. I can see from the patient perspective being home is absolutely fantastic, but how do you also allocate a number of hours a day where you're glued to your computer and you're ready to, thank you, you're ready to accept phone calls or a video conference or something from a patient? So it's the everyday practicalities of you working as a team, but somehow where, how?
So we are in a room in the hospital.
There is a room, a physical room.
A physical room.
And the team assemble at 8:30, 9 o'clock with a morning meeting, as they would on the normal ward, with the junior doctors, and they work through all the clinical problems that morning. And then every day at 12 o'clock, we have an hour-long ward round of all the patients, which is attended by a consultant. We then allocate all the jobs for the rest of the afternoon, resolving unresolved issues. And that cycle repeats 7 days a week, so every day of the year.
So from a nursing perspective, the patients, we have 2 different sort of sets of kit that we send patients home with. We have what we call our intermittent kit, where patients can upload their observations once, twice, 3 times, or even 4 times a day, depending on why they're with us. And we have nurses that watch that dashboard and watch those observations come in. Those nurses will also video call the patients every day. So every patient gets a video call with a chat of how are you doing, how are you feeling, all the kind of nosy nursey questions, and we check their medications with them. We also have what we call our continuous kit. So a lot of our cardiac and respiratory patients will wear wearable technology, so a little wristband or a little cardiac monitor that will give us observations every 15 minutes. The cardiac monitor will also give us a rhythm strip, so we can identify very quickly when the patient falls out of their parameters. So if somebody's heart rate goes up or goes down, or if they fall out of their parameters, we will video call them and say, is everything okay? Sometimes it's, they've just dozed off to sleep, so the heart rate's gone down. It could be that they just run up and down the stairs, but we keep a really close eye on our patients. Does that answer the question?
It does. I do have another one, if I may.
Of course.
It's the patient cohort. I mean, the people you select to be in this virtual hospital clearly have to be tech savvy, don't they? They have to be able to use all of the kit. Norfolk, and I guess Suffolk and all the other regions, we're an ageing population. A lot of people, certainly amongst my own personal group, do not use computers, don't use their mobile phones. So actually that is going to exclude a great many people who could well value having their own.
We thought it would when we started, but actually we found that it really doesn't. The kit that we use is quite simplistic. It's very sort of plug and play. Before anybody leaves the hospital, we do a full demonstration of the kit with them. So we do an assessment with all our patients, and we do a full observations with them. So they get good demo. All of our nurses are really good at troubleshooting and talking people through the kit once they're home. But we've also found that most people will have friends, relatives, grandchildren, children that will help them with that. One example is I went to go and see a 99-year-old, and I thought, we're going to really struggle here. And she literally went, I don't know, I don't do technology, I'm not going to be able to help. I'm not going to be able to do this. And I said, well, let's give it a go. Let's talk through it and see how far you get. I said, but before we start, have you got your next of kin's telephone number? And she pulled out an iPhone and went, hold on a minute, let me just get the phone. There it is. And I went, you'll be fine. Because if you can use a smartphone, you can use the kit. And I know there are lots of people out there that don't use smartphones, but we have become so kind of, we've done it so many times now that we're able to adapt our teaching and able to make it as simple as we possibly can for patients.
I have to say the average age on our virtual ward is not young. They're not young patients, and you'd be amazed at how patients really adapt to it. And there's good evidence from around the country that it's been successfully used by patients in all age groups, particularly the older patient, which is why we think it would be really useful for us here in Norfolk.
great, fantastic.
So just one last follow-up. If a patient needs to come back in quickly, can you facilitate that?
Absolutely. So there are different ways back in. So if there's an absolute crisis, it's call an ambulance and go to the emergency department. But what we try and do is avoid that and keep a very close eye on patients. And so if we see things changing, we will perhaps get someone in for a face-to-face assessment and then make a decision about whether they need readmission to hospital or not.
There's one at the
Yes,
back.
just 2 points. People to the virtual ward. What's the average stay?
Average length of stay is just under 7 days. Just over 7 days, 7.06 days this morning. It varies, and who allocates it is a consultant-led decision. So a consultant or a doctor will identify the patient as potentially coming to the virtual ward, and then one of the virtual ward team will then go and assess that patient and say, yes, we can manage that, yes, we can do that at home, or no, we can't.
I'd like to add that some of our length of stay data has been influenced by the fact that the patients actually love it so much that they don't want to be discharged from the virtual ward.
Can I just heap a bit more praise upon you guys?
Thank you.
Last year, I've never really been in hospital before, but I found myself in hospital having major surgery with sepsis. And I found myself in the ITU, and I found myself in lots of other wards, and then I found myself on the virtual ward. And can I say, I think all of you guys do an exceptional job.
Thank you.
You met my deepest need, and you were there early hours of the morning. You were there many times, and if I had a hat on, I'll take it off to you. Brilliant. Well done.
Thank you so much. Thank you. That says it all, really. Thank you very much.
Our next clinical presentation, Improving Care for Women with Severe Nausea and Vomiting During Pregnancy, from Laura Allen, Quality Improvement Lead Midwife, and Beth Laverick, Lead Obstetrician for Maternal Medicine.
I might use this initially.
Hi, good evening everyone. Thank you for the opportunity to present our project. Sorry. Oh yeah, I hear the difference now. Looking at using ambulatory care to support women with nausea and vomiting during pregnancy. I'm Beth Laverick, I'm a consultant obstetrician and the lead for maternal medicine here. And Laura, your role has changed slightly.
So I'm now the Risk and Governance Manager for Maternity and Paediatrics.
And the other way, you handed that to me upside down. First bit of problem solving. Key to any quality improvement project. So our project looked at reducing the impact of nausea and vomiting in pregnancy, and as I've said, taking an ambulatory approach to this. So nausea and vomiting in pregnancy is very common. It's experienced in some form by the majority of pregnant women. And we know there is a severe form of nausea and vomiting in pregnancy, hyperemesis gravidarum, that affects between 4 and 10% of women. And this form has really significant social, psychological and physical impact for this group of women, and can have really long-lasting impacts, not only on the sort of clinical aspects of the pregnancy, including fetal growth and maternal mental health, but also long-term impacts for the woman and her family. We have really good options for care, for good care. It's safe and easy. It's not groundbreaking research that's needed in this area. It's just finding good and accessible ways to deliver very simple care, which is effective antiemetics, providing a holistic approach, and IV rehydration. We worked with our local Maternity Neonatal Voices partnership to survey women and their families using our service, and we did this predominantly via social media and our clinics to understand what the difficulties people faced in accessing care. We also, in addition to this, surveyed our clinicians and midwives to take account of their understanding and their approaches to care in this area. Results from the survey mirrored what we, and from both patients and the midwives, mirrored what was found nationally, is that women often face a really long and difficult journey to access good care for this condition. Data shows that they often will have up to 5 attendances with medical professionals of different types before being offered evidence-based care and access to the treatments or medications that could help them, by which time they're often in a much worse clinical and psychological state than they would have been. And it can really impact the sort of approach and relationship they have with accessing medical and maternity care. And here's one of our service users, or a few of our service users.
My name's Georgia. I'm Laura Canning. So I'm Hannah Oxborough. I had hyperemesis in my first pregnancy in 2022, and I'm now 17 weeks pregnant.
Each of my 3 pregnancies I have suffered with hyperemesis.
First started being sick probably about 6 weeks.
Well, it was just, I couldn't do anything, so my quality of life just felt non-existent during those times.
And it was only really at that point when I was struggling to eat or drink or move, which was pretty extreme. You know, I think I waited until it was a very extreme level before I asked for help, that I was like, this cannot be something I've expected to just put up with. And that's when I first spoke to the GP.
And I approached the doctors, as you do, and it was just like, oh yeah, this is just a normal.
It was hard, like with just doctors and stuff, to try and get the right help from early on. I did come up to hospital a lot for hospital admissions.
Because there's been a cycle of kind of patch you up, send you home, come back without anything effective.
And it was scary as well, because especially my first pregnancy, because you don't know what's normal and what's not.
Obviously there is a toll on the whole family. My daughter's had to get more used to me not being able to do things, which, you know, she's 2,
So at the moment he's got a little chart which is a countdown to baby sister arriving and mummy not being sick.
My 3rd pregnancy this time round was probably my hardest overall, because I had 2 other children which I couldn't look after them.
Hyperemesis is really exhausting. So feeling like you're going to have to argue with somebody to get help for it is just like such an extra level of stress and anxiety and difficulty at a time when you just really don't have the resources to deal with it.
Okay, so in response to this, we altered a number of things. So firstly, we now offer pre-pregnancy counselling for those who've experienced nausea and vomiting in the past, and it's also included for those people who perhaps don't have the most severe form of nausea and vomiting, but they do have to take other medications, or and having a small amount of nausea and vomiting actually is really impactful if they can't take their antidepressant medication or anti-epileptic medication. And they're signposted to help early. So now from booking, where most people booking a pregnancy will book online, and now they receive an email or a page that will refer them to help if they do have nausea and vomiting in pregnancy. We worked with our community midwives to develop a resource. One of the things that kept coming up was that they felt underprepared, and the patients also felt they were under-equipped to actually advise and help them. Nausea and vomiting isn't something that features particularly heavily, despite being so common in midwifery curricula. So we've addressed this by providing teaching at an undergraduate level for midwives, providing education sessions, and also developing a resource which will come up on a future slide, which really equips midwives to actually not just kind of signpost patients, but also empowers them to understand what actually is available, and give them confidence in taking medication and accessing care. On the emergency gynecology ward, women felt that they waited for a long time and perhaps didn't really understand the process, so they're now given a what to expect information leaflet and ways that they can prepare for their review. There's a weekly teleclinic appointment which is associated with the virtual ward to ensure that medications are optimised and prevent reattendance to the hospital. One of the biggest innovations by far is our relationship that we've developed with the virtual ward and the home IV service. And this has given women the opportunity to be at home and to have access to the hospital when they need it, and when they're really hyperemesis and severe nausea and vomiting tends to go through good periods, and then if left without care and support, women really can find themselves sort of dropping off a cliff with symptoms, and I think this service has really prevented that. So an option to come in, and for those who are experiencing it throughout the pregnancy, they're able to access IV treatment with IV antiemetics and fluids in their own home. This is the midwife resource that we have created, which actually has subsequently been used within the virtual ward staff as well, and has been a really useful tool to help midwives assess and refer appropriately. We also encouraged email access to us in association with this resource. I think this has been one of the great pleasures of this service, is seeing how empowered the midwives have felt to actually provide this support themselves, and they're referring people up. So we have had a slight uptake in the people who are accessing care, which is a good thing.
So, I mean, this kind of goes back to your slides a little bit, but just I won't go through this one too much, just about what we've created. But in terms of the kit as well, we've got a slide here. So this is what it looks like when the women go home, or other patients that are on the virtual ward. But we've just made things a little bit more bespoke. So we use the PUTE score that's on the community midwifery resource, so they can do that score, like that one. So yeah, they're doing their score every day. So we're able to see where they're at in their journey. This is the pregnancy unique quantification of emesis.
Yes.
There we go. So yeah, and like it's been explained before, these women have regular contact with the nurses on the virtual ward team, so we can really see where they're at on a day-to-day basis. So this was a QI project, and initially it was kind of an idea that Beth came to me with probably about 2 years ago now, and then we kind of took an opportunity when the maternity sustainability challenge came up last year around now, wasn't it? So we had 16 weeks to design, implement, analyse everything for this project. So we looked at 2 periods in time. So we looked at October last year, and specifically the admissions to our gynecology ward for women with hyperemesis. We implemented these pathways, the relationships we developed with the virtual wards, and then we looked at the data again in December. The clinical impact, we've updated slightly with the numbers there, but at the moment we've seen 130 patients reviewed in the teleclinic, 35 patients have been admitted to the virtual ward, 9 have then attended the virtual ward hub for treatment, so that's when we've identified that their condition is deteriorating and we bring them in for those fluids, and 7 women have actually received IV treatments in their own home, which is absolutely amazing. It was a sustainability challenge, so we did lots of maths and learnt lots of new things. But, looking at the items that we use, down to taking bloods and setting up fluids and laundry and everything that comes with a patient admission. So we saved the equivalent of 23.4 trips from Land's End to John O'Groats just in that 1 month alone. And the financial impact, although we were asked to look at this, although it's not a direct cost saving for the trust, but obviously it has a massive implication for the waiting lists, the acuity on the gynecology ward. So we had 22.9 bed days in October attributed to women with hyperemesis, and in December only 9.8. We have included the virtual ward days, but as Claire's already said, these are significantly cheaper than an inpatient ward bed day. So the total saving for that month was estimated at around £63,000, with a projected annual saving of over 760, so pretty big. And we wanted to just hand you back to our service user group to tell you about the social benefits.
Having the appointments with, or the calls with Sophie every week or twice a week, helped because we could just adjust things in sort of real time. It wasn't like I was waiting for things to get worse before we would adjust things. So that was loads better because it meant it just felt like we were kind of maybe not one step ahead of it all the time, but keeping pace with it at least.
And it was just like everything was just, you need this is going to sort you. Do you know what I mean? Like I was really looked after. And from then onwards, the rest of the pregnancy, I couldn't have asked for any better care.
And then I was with the virtual ward for a few weeks. I only went in for IV fluids once, but that was really good to know that they were there.
At home, like yesterday's treatment was literally, I done school run, they came in, literally I'd started and I then started work straight away after. I had half an hour gap afterwards and straight away started work, which meant worked really well.
It was just like such a relief to know that there are people who are listening, who understand, who I'm not going to have to argue with.
Once I've had my fluids and my anti-sickness in me, I then sort of kind of have a new lease of life the next day.
You know, there comes a point where you just can't, you get beyond being able to help yourself, and I think never getting to that point has made it a lot better this time.
After having 3 pregnancies, all with a lot of medication, including the ondansetron, I've had 3 incredibly healthy babies, and you just never know.
I think we were incredibly lucky to have a very engaged group of service users who kindly agreed to sharing these in multiple forums now. And I think it speaks volumes that they've actually subsequently reached out to us with ideas for support groups, for modules, for things to be incorporated within modules for sort of late teenagers and university age students, which is a real privilege to be thought of in that aspect. We are currently working with that group of service users to develop a patient resource, which we hope to be available, and we think is something that actually within the maternal medicine networks that we are part of, that we would be something that would be of interest nationally, and we are also working closely with the charity Pregnancy Sickness Support to develop that as well. And alongside that comes that working with that community care, so ensuring that GPs are involved. We do continue to deliver lots of education and resource provision, and we, as a team, went on a little roadshow out to Great Yarmouth and have had a lot of enthusiasm, met with their virtual ward team and obstetric team, and I think are imminently going to have their first patient, and we hope to sort of collect the data from that and really think about this as something. We've also had interest from QEH as well, and we really see this as something that could be sort of packaged together as a toolkit for other trusts to implement, and I think is the missing piece in sort of improving care for this group of women. What are the strengths of the project? Well, I think we've sort of challenged something that's been hyperemesis and nausea and vomiting care has kind of sat under the gynecology remit for a while, and has really kind of been shoehorned amongst people having cancer surgery, other early pregnancy problems, and no one's really kind of looked at it in isolation and thought, how can we improve the delivery of care? And it has taken sort of someone to take focus and ownership of it to really consider how we might do that. It's quite a unique multidisciplinary team, so obstetrician, midwife, gynecology nurses, obstetric physicians, virtual ward teams, IV fluids at home, Dr. Pastor and Dr. Ampe understanding nausea and vomiting in pregnancy, but really just a willingness for people to want to make a difference for this group of people, and enthusiasm has really carried this through. We have had really wide engagement, and service user and staff voice has been at the heart of it, which I think has really ensured the success. The challenges I think I've really touched upon in there, it has been a bit of a culture shift. There's been a bit of a move to try and improve care for a while, but perhaps it's not been done. And it's sometimes easy to find reasons why something can't be done, as opposed to why aren't we just doing it. It has challenged traditional models of care, but I think the real joy has been in the interspecialty working.
This is my slide.
Yeah, go on.
I
You
get to
can
talk
talk
about all the good things. So we're really, really proud of what we've done. And like I say, this started as the Green Maternity Challenge, of which we won at the beginning of this year. Then we were asked to present at the RCOG Green Maternity Conference in March this year, and we were awarded Best Presentation there also. And then we went on to present at the Centre for Sustainable Healthcare Conference. And we also, Beth took a poster to the RCOG World Congress. So this work is really spreading widely. We were shortlisted as finalists in 2 categories, the Virtual Remote Care Initiative and the Maternity and Midwifery Incentive of the Year for the HSJ Patient Safety Awards. And we are presenting next week. We've been finalists for the HSJ Awards, so we've got one more award we're hoping to add to our collection, but word is really spreading, and as we do these talks to all these different forums and people that have never even experienced maternity care, those providers, we are getting so many questions like, can we do this? Like, pinch with pride is like the line I get once we've done this presentation. And also, not just in the UK as well, we've had interest outside of the UK. Like, this should be something that can be done anywhere. So we just wanted to end with this, because we've said lots and lots of times, I think there's pockets of excellence like throughout this trust, and I think we're all going about doing our things, but if we just get our heads together, we can make some really great things happen. So yeah, it was just a thank you to everybody. And those are just some quotes from our women and our staff. Thank you. Any questions?
Sorry, me again. There will be hard-to-reach groups of women suffering silently in various places. Do you have plans to reach them?
Yeah, I think sadly this has been a group where there's almost the majority. I guess they haven't been hard to reach because perhaps we haven't been trying to reach them. But you're right, we do have to consider that. I think having this embedded in community midwifery and at that point of booking, the routes to access care help. But across all of maternity care, that's something that is always on our mind, and also how representative our service user voice is.
Thank you.
Thank you.
Presentation of the annual accounts from Marcus Thorman, Group Chief Finance Officer.
Hey, good evening, everyone. What have you... It always feels like when you've had clinical presentations that I've probably got the graveyard slot now. So if you're not interested in the numbers, if you nod off, I will be very accommodating of that. But 2 brilliant presentations. Really pleased to see that you included the financials in both presentations. So that was very impressive. And some very impressive numbers in terms of there as well, so in terms of what you're doing. But let's kick on with the accounts for the financial year 2024-25. So, just taking you through the key sort of numbers in terms of the position in 24-25. I always like to look at the year, not just in, look at sort of 3-year trend and not just 1 year in isolation. So you can see it's almost invisible there, but the surplus, we broadly hit a break-even position in each of the last 3 years. So that's really good. If you look around the country, and for those that read the press around the NHS, that most organisations are really struggling financially. So to deliver that 3 years in a row is absolutely excellent. Our cash balance has stayed stable as well, which is underpinned by that, but also the fact that Lesley talked about it earlier, and I'll come up to it at the end, around the investment that we've had in our capital resources over the last year and over the last few years as well. We spent 70 million last year, and a lot of that was supported by national money through bids that we have won in this organisation. And then you can see our income and how our income has grown over the last 3 years. We had a 10% increase in our income in comparison with the previous year. So just dipping into the income in a little bit more, it's grown over £163 million since 2022-23. So we're now well over £1 billion as an organisation. And has grown by 18% since over those 3-year period. The biggest area is our commission services, so the healthcare, the sorts of things that you've just been hearing about, the healthcare provision that we provide, which is no surprise, we're a hospital, so that's the biggest growth that we've had. We have had some other growth as well, and you can see that we've had quite a growth in our education and training and our other income. Other income in total includes a lot of things, so it's things like our research, which is again really interesting in terms of the organisation, significant amount of research income that comes through, and then things like the Cancer Alliance, so that we get quite a bit of money through from the Cancer Alliance as well. Moving on to our expenditure. That you will see that staff costs makes up, usually it's around 60% if you look at an NHS organisation. Again, no real surprise with regards to that. It's grown quite a bit in the last couple of years because there's been some significant, and again, you'll have seen it in the news, the industrial action that is around pay awards and whatever else. And so that has seen quite an increase in pay over the last couple of years. But interesting to note that that drugs hasn't, I probably should have put the percentages on here as well, but drugs hasn't grown as fast as our income has grown, which if you think about a hospital, as the hospital's income grows, that just means that it's doing more activity. You'd expect drugs to grow in a similar proportion, and it hasn't. And that's because we've done a lot of work around our cost improvements and switching out to more generic drugs, etc., etc. So work that's done by our frontline clinicians, and meant that despite our income overall rising by 10%, our drugs bill only rose by about 5%, which is really good news. Clinical supplies did rise by broadly the same amount. And then you've got, if you look at our premises, mostly that's the building that we're sat in. This hospital is under a PFI scheme and is for another about decade. And so there's a significant cost that goes through on that. And then final slide, picking up our capital expenditure, which has already been talked about by Lesley, £70 million invested. CDC was a key asset that opened in February, which is our community diagnostic centre, which is just across the way. 5 MRI scanners, 4 CT scanners, 2 ultrasounds, and 2 X-ray rooms. It feels like the 12 days of Christmas, doesn't it? You also want to sing that, don't you, that last bit? But the facility's open 8 till 8, 7 days a week, and when it's full, we will be able to see over 400 patients a day. So fantastic amount of additional capacity that the organisation has got. There's also a number of other things that we've spent, so replacing equipment. As I said, this building is a PFI building, so that gets maintained by the PFI contractor, but all the equipment that's in the building is things that we would have to replace and put through. So that's the accounts for the year. I just want to just note that the accounts were laid before Parliament in the timescale that was required. And I really want to give a thanks to the finance team for all the hard work that they put in during the year, and particularly during the accounts period. I've been a CFO in 5 different organisations across nearly 20 years, and I think this is probably the best. I probably should tell them this as well, shouldn't I? But the best and smoothest process I've seen of putting a set of accounts together. So they've done a really good job, and I want to congratulate them for it. So thank you very much.
Presentation from the hospital governors.
Hi everyone. Gosh, like Marcus, I'm kind of thinking, how do I follow on from such inspirational speakers, clinicians? And not that I'm saying yours wasn't inspirational, Marcus, in any shape or form.
So, I know where the credit should go.
I'm not very good with numbers and figures, so is this just a...
It's just the yellow button.
Perfect. Thank you so much for allowing us the opportunity to share with us what governors get up to. It's an absolute pleasure to be here, and I hope you learn a little bit about what we do. My name is Elaine Bailey. I am the Public Governor for North Norfolk, with another colleague of mine who's present here today. We comprise 23 governors overall, so I'm representing the other 22. And pretty much 3/4 of them are in the room at the moment, so there's absolutely no pressure here. So some of you will already know what governors get up to, but as we engage with our public, I think all of governors find that sometimes people don't really understand what governors do, and I think probably it's really helpful for me to share a little bit about it and just to sort of re-emphasise what our priorities are. So, now, we absolutely love our acronyms, as you know, in the NHS. And the Council of Governors is no exception. So I'd like to think we're affectionately called the COG. And as I was sort of putting this presentation together, I thought, that's a really good analogy, a COG. So we have 23 governors in total, and that's made up of 5 elective staff governors, 17 publicly elected governors, and we have one who's appointed who represents the local authority. And you'll meet some of them in the video later. So if you think about each governor as a cog, as a tooth on the cog, so we all come from diverse backgrounds with very different skill sets, each hugely valued individually in their own right, and collectively forming a wheel that's strong and effective. So our cog then aligns with the others within the NNUH and the wider community. And the connection then enables governors to link members, the public, and staff with the board, and we kind of keeps the whole system running together. And, as Lesley and Mark both shared, we can make the decisions together. Now, what have I done there? Try again. So just a little bit more meat on the bones in terms of what we do. These are our functions. So it's debatable, but from my perspective, this is the most important function. Our engagement with the staff, the public, the patients, the membership, and the wider community. Hugely important for us to engage with them, because the more we engage with them, the more we understand what their issues are, what their positives are, what the negatives are, and we then in turn can share. So as important as engagement is representation. So we engage with them, we hear from them, and then we represent them, members, patients, staff, and the public, by sharing the feedback, and we share that with the board. We also have an oversight responsibility, so we hold our non-executive directors to account for the performance of the board. And we do that in a variety of ways. We do that both informally and formally. So informally it can be a corridor conversation with one of them. Joe's sitting in the audience there. Lots of corridor conversations with Joe. And on a more formal basis, we can attend, as anyone can, public board meetings, and we're also very privileged to observe some of the Assurance Committee meetings as well. So by that, we can actually hold our NEDs to account. Final, and probably the busiest time at the moment, is approving new non-exec appointments, participating in chair selection and contributing to their performance evaluation. That's kept us fairly busy, especially over the last few weeks, and will continue to do so, I think, for the coming weeks as well. So probably important for me now to share with you our governors and to give you their perspective in terms of why they became governors and the focus of their attention whilst they're doing their role. So thanks.
My name is Cherry Cubello and I am a staff governor. I have been elected to represent nursing and midwifery. I can guarantee you that I will hear your diverse voice and will take action that can take us to an inclusive future.
I've spent most of my career working in the NHS, and I thought I'd have something to offer. Some insight into how the NHS works, and that I could perhaps bring that knowledge forward to help shape the current NHS in this area. I've really enjoyed being able to hold to account some of the executives and non-executives to analyse the risks on the decisions they're taking, I hope in a way that makes it better for patients, which is obviously why we're all here in the first place.
As part of my role as governor, I attend regularly care assurance visits on wards and in departments. We listen to what patients say, good and bad. We hear what staff are saying, and we acknowledge the hard work they do. Making staff aware what they're doing well puts a huge and much-deserved smile on their faces. And making them aware of any shortcomings initiates change for the better. So on both accounts, it's a win.
One of the major decisive factor in choosing to become a public governor in Norfolk Norwich University Hospital, representing the broader council, was related to the fact that I was a consultant in medical oncology at Norfolk Norwich University Hospital for almost 20 years. In the current role as a public governor, I feel that my voice is now heard through the official channels and through the council governance meetings, and the patient's care, particularly the oncological care, is sustained to the highest level of professionalism.
I'm a staff governor. In addition to governor duty, I come hospital almost every week. I love to speaking with patient and their relative. As a governor, I would like to thank you to all staff of hospital.
I became a governor to support continuous improvement in patient care and to represent the views of our staff. We've established a dedicated working group to ensure staff voices are heard, and as part of this we now run a dedicated drop-in session 3 times a month where staff can come to share concerns, ideas or anything that they wish to discuss.
I've been a governor for over 4 years, and my background is in financial services, and so I thought I could help to steer the governors to understand the complicated financial accounts in the NHS, and we've been working very hard this year on bringing the 3 groups of governors together from the QEH and the James Paget Hospital, so we can work as one group, as a board, going forward and hold the non-exec directors to account.
The people of North Norfolk are incredibly proud of Cromer Hospital. And over the years we've developed more and more services. We have a minor injuries unit, we do minor operations as day theatre operations, we've got more clinics, we've got our brand new Macmillan unit, we do scans, and in the last few years we've developed a new cafe on the front of the hospital.
I've been a public governor for Bleakley for 10 years. It has allowed me to learn about how this hospital operates and the many specialist services it offers. I take part in care assurance and place visits so that I can talk to patients about the care they receive, and I sit as an observer on subcommittees of the board.
One of the strengths of the Council of Governors is the diversity of our backgrounds, making us a real strong team. Part of the role which I enjoy most is engaging with public and patients. Talking with families, carers and patients gives us a real insight into what matters most. I've been genuinely impressed with the leadership and the staff here at the hospital and their dedication to providing high quality care.
In February 2020, my wife was admitted to the Norfolk Norwich Hospital with a blood clot on her liver. She was given days to live. She was transferred to the Mulbarton ward, where the nurses and doctors, for 22 days, nursed her back to life. I can't thank the hospital, the doctors and the nurses enough for the fantastic treatment we both received during those 22 days.
I would urge anyone who is interested in becoming a governor to think about it seriously. It's a wonderful experience.
Thank you. Thanks for that. You probably have in your packs already the list of the achievements over the last year. As Mark said, we are a really busy council and we do an inordinate amount. And if it was me, I'd try and do even more. I know lots of others would. But I just single out just a few of these because I think these are the really, really important things where I really, truly believe we've made a huge difference. We participated in care assurance and place audits. Like Inna's saying, we identify areas of best practice, but there are also areas where we might actually challenge, and maybe then staff might reconsider how they can actually attain best practice. Visiting hospital departments to meet the staff and hear first-hand experiences. Kevin's absolutely right. This is our bread and butter. This is where we find out what's going on, and then we feed that back to the board. The link thing, I'm especially proud of this one because over the past few months, we've actually sort of been considering how we can involve younger people in the governance support. And particularly Innes and Annie have been instrumental in developing really, really strong links. And I know Joe's progressing that. So I think that's a huge opportunity for us to really engage with younger people. Just talking about that, engaging with our trust members, patients and the community through events and surveys. Again, we undertook a survey at the Norfolk Show to actually find out from people what they felt they wanted from membership. We feel there's quite a bit of work to do with our members at the moment, just to see what more we can do, what more we can provide for them. And the final bit, the groups bit, we have actually worked really hard to implement working groups. As I said, if it was me, I'd try and do everything, but Tom actually, in his infinite wisdom, discouraged that and said, no, hang on a second, let's just concentrate on a few things and be good at a few things rather than okay at a lot. So I'm really encouraged by those working groups. We've got a long way to go, but I think they've really, really helped us to progress over the year. So that's a little bit of an overview of what we've done. So priorities for the coming year, pretty much the same. Strengthen our links with our patients, our staff and our community. Support the leadership and governance, hugely important as we go to group model to ensure that we continue to hold the NEDs to account for the performance of the board. And finally, and I guess this is the thing that I think we're really, really excited about, is fostering collaboration within our group now, aside of our NNN and across the wider ICB. So you'll see my little analogy, and we've now got 3 COGs. So we are now, again, with Tom's huge support, we've actually started collaborating with our governors in Queen Elizabeth and James Paget. And there's already so much amazing shared learning that's gone on. So we really look forward to embracing the challenge and working together as a group as we move forward. So that's kind of about it, aside of thank yous. And I don't want to stand here like an Academy Award winner and thank the whole world, but I think I do need to single out just a couple of, groups of people. So first of all, I've got to thank my fellow governors. Inspirational. Thank you so much for all you've done. It's been an absolute pleasure working with you over the past year. I know we've got loads more to do, but your energy, vibrancy, enthusiasm, support, second to none. So thank you so much for that. I'd also like to thank the members, patients and staff for their support over the year. They've generously given so much time and so much feedback, which is hugely important to our role. And we're really encouraged to see how their contribution has helped the Trust and the group to advance its commitment to patient-centred services. And the final big shout has to go to the multidisciplinary teams, clinical and non-clinical, not only in the hospital, not only at JPH, not only at QEH, but across the wider community for all the amazing care that they continue to provide for us. Thank you.
Looking ahead with Executive Managing Director, Tracey Bleakley.
Thank you very much, everyone. It's great to be here. Have a bit of a trick question for you. What is a hospital? So we're looking ahead at the future for our hospital. And I'm going to challenge us all because, for me, a hospital is not a building or a group of buildings. And this is a great place here, isn't it? You know, we've got this great facility, We've got a great facility up at Cromer. We've just seen some of the pictures for those of you not familiar. Other facilities such as Bowthorpe. But actually for me, a hospital is about a community, which is our staff, our volunteers, our patients, our stakeholders. And my goodness, we've got a strong community. And it's also about a philosophy of care. And that is a philosophy that will help to keep everybody living in our area in Norfolk safe and well and happy and enjoying their lives. And that is what we're all working so hard to do. So what do our patients tell us? What do they want in the future? Well, they've just been telling us how safe our care is, and we've just had a fantastic patient safety survey, patient feedback, and we're going to be putting that around the hospital because on so many areas we get more than 9 out of 10 of our patients telling us how much they value the care here. But they also tell us how difficult it can be getting here. Getting in their car, coming here, parking, the time it takes out of their lives, how difficult it can be working around their jobs, for example. And if you're visiting somebody, a loved one is here, how difficult that can be to get here. So what they'd really like, if we're thinking about keeping people at home, getting on with their lives healthy, is as much treatment as possible in their homes, whether it's where they live or whether it's where they're living in a care home, for example. That is still their home. And then when they're ill and they're frightened, they don't necessarily want to be in a hospital. They want to be in a place that they feel safe. So that is part of the reason we had the 2 presentations, the fantastic presentations here today, because that is demonstrating how a hospital, a community of people, can help people feel safe in their own homes and then get even more care at home. So what does the future look like? And I think Sundri was outlining a lot of this earlier, which is just so exciting. A 4th hospital, keeping people at home safer, working together. So with our virtual wards, you saw on the screen, if you're waiting for an operation and you're not very well, do you need to be here or can we be looking after you at home? When you come in, can we shorten the length of time that you're here? Quick plug, we are raising money for 2 new robots for surgery, and Marcus is working really hard to make that money stretch potentially to 3 robots. So the more you can help publicise the work of our charity to go out and do that, the length of time that we keep people here in our hospital dramatically reduces. If you happen to be in intensive care, the team there are doing amazing work on rehabilitation, and I wished we could have had a 3rd speech today for that team to tell you the amazing work they're doing to get people well quickly, back into the wards and back home. And then we can get people back home quicker on virtual ward. Somebody asked a question about how we know how we contact people. When I was down with the team, I remember that we actually saw somebody's blood pressure was raising, and Claire actually contacted that person in real time to say, "Are you okay?" And bless him, he said, "Yes, sorry, I just walked my dog, is that okay?" It's more than okay. He was getting on with his life, and he was getting well quicker, and that's what we want to see. And if it's not an operation you need, but it's the middle of the night and you're in a care home and you've got flu and the care home nurse is getting really, really concerned, do we really want to blue light you into our hospital? It's a great place to be, but it's a frightening place to be, especially if you've got early signs of dementia. So how can we work better with our community nursing teams to plan and schedule for you to come in the following day, be looked after in the care home at night where you feel safe, and plan that care so we can look after you in the most appropriate way. So that's what's driving us. Nobody in this room can be immune to the fact that we are building so many new houses in Norfolk and Waveney. The number of people living here is growing and growing. This hospital was designed for 800 beds. It's a terrific place, but we've got anywhere between 1,200 and 1,300 beds in it at the moment. We cannot fit another 500 beds in here. But everybody has a bed where they live at home or in their care home, and that's where we want to keep people, and that is how we will expand. Now, we're not an organisation on our own. Our community is part of a bigger community, and that is part of joining the group, and there are so many exciting opportunities part of our group. but it's also about working within our place, with our community partners, with our fantastic GPs. And we've got so much technology to look forward to. We've got our electronic patient record coming next year. Just over there, behind some doors, is our hub where we're working within not just this hospital, but across the group to get us onto an electronic patient record. But we already have a shared patient record already, linking us up with our local authority colleagues as well as across health and social care, and also with our voluntary sector. And we know that primary care here in Norfolk is light years ahead of the rest of the country. Doing prevention, our stats around the way people feel about GPs, not just patient satisfaction, but how quickly they can get an appointment, a face-to-face appointment, and be seen in 48 hours is so much higher than the rest of the country. So we're going to capitalise on that. We'll be using wearable technology. So you don't have to necessarily even know how to use a smartphone. The technology will not only be able to treat you and send you home safely, but what if it could have 3 other points of prevention as well to look at what you might be facing in the future? We're working with our mental health colleagues at NSFT. We're looking at how we can make our emergency department a safer place. But what if we could do whole mind-body pathways? Because it's very rare that somebody will have a mental health issue without a physical health issue or the other way around. And what if we could do more to predict crises and stop them happening? Using our extensive data and the data that we have within our general practice and our local authority, what if we could do so much more to say, we're starting this treatment, we think this might happen in the future, let's talk about it, let's prevent it, let's use that wearable technology. Because at the end of the day, yes, it's about living within our means, and we absolutely have to do that. And yes, it's about delivering excellent care. And I think that you've seen everyone in our hospital, our community, is absolutely driven to doing that. But what we're really all here for is for everybody who lives in Norfolk, everybody who relies on our hospital and the wider services, because we want to keep people healthy, we want to keep people well and enjoying their lives. That's what the future looks like. I think it's really exciting. I think you can see that all of our staff and all of our volunteers, our governors, our wider stakeholders think it's really exciting as well. You're all a part of that. So thank you in advance. Thank you very much. I knew I would forget. I need to just look back for 1 second. So this was about the future. But we have a member of staff here, Janice Bradfield, who was organised today, and today is her last day in the hospital. Janice has been a fixture in our hospital for so many years. Don't cry, Janice. But we do need you to come up here so that we can all say thank you to you, and we've got a little something for you. Today happen.
Next, we have the Q&A session with the leadership team.
We've got one here. I'll break your duck for you. My name is Ian Carstairs, and I'm just a member of the public, and I'm a person whose family have had exceptional, extensive support through this hospital. So what I'm going to say now, I want you to see in the context of just how much we have valued what goes on here. Fantastic. I'm probably in a reasonably unique position, sadly in a unique position, is that because my wife can't see, I spend many, many hours here. She's in here now, and there's her brother. I spend many hours sitting, just keeping things steady, helping the staff going through it. And one of the things which I've experienced, and I've obviously heard from the staff, I've talked to a lot of your research people today, I've talked to your staff welfare people today, and in listening to them, particularly in the escalation wards, I mean, I'd like to suggest, and this is not a complaint, I assure you, I'd like to suggest that there is an element of the work in there where there are certain things that could be looked at which would be beneficial to staff welfare, will be beneficial to patient welfare. And actually, I think if a proper cost-benefit analysis was done of it, that you would find that actually expenditure on ensuring there was somewhat more support in terms, actually, basically, physically, day-to-day physiotherapy, not even physiotherapy. I mean, I think in the past, they had people come into those wards who would come and get everyone doing things, and I don't know, you know, this sort of stuff. Staff morale up, patient morale up, patients go earlier. Some maybe not even need to go to rehab where they would. And I wouldn't mind betting you, I don't know what the figures are of what this cost you in the past, but I wouldn't mind betting you that if it was 500 quid a day, you only need one person not to be staying another night overnight in there, and there's a 1,500 quid bed for you, you know. So the bottom line of all of this and me coming today is that, I mean, you like people from the outside to come and comment. I see so much stupid criticism on the television of it, and I think there's always a truth behind these things that's not what you see. And my experience is nothing like all of that, what I consider to be rubbish. But I've offered with the charity and to look at the research people as whether you'd be willing to accept someone from the outside working with you in a very simple way to just look at a scoping study to just see what the benefits would be from re-injecting into that particular part of the hospital's work. I think the great advantage with this from your point of view is that it is a very discrete element that if there is another expenditure, if there is a way of evaluating it, it's not something which is hospital-wide, so you've therefore got a financial consequence through all of your departments. And I will chat to the charity people and I will chat to the research people, and I hope as a group that you'd be willing to accept, I hope, helpful thoughts from the outside. And if in the end it can't be done, fine. But at least I do think that you should look at it. I hope that's helpful. Thank you.
If it's on. Thank you very much. I think Julie has given me your contact details today, so I will email you in the next 24 hours and make contact. We have in the past had support from exactly families like yourself who've been able to describe, and actually on one of the videos I saw today, you saw our Can You Reach campaign, which was actually driven from a family member who did some work with our quality improvement team to make sure that as we move away from a patient, they actually can reach the things they need to. It was so simple and so straightforward, and yet we in every day don't see it all the time because we're part of it. So thank you for that, and we will reach out. Thank you.
And just to follow up on that, obviously as a university teaching hospital, we are very keen to be as active and involved in innovation and research as possible. And the sort of issue that you've raised is one of the vital ones, not just for this hospital, actually for the country, in fact, most of the world, in that as we have an ageing population and making sure that our patients, both in the hospital and out the hospital, have proper rehabilitation, we avoid deconditioning, make sure people can get home earlier and can stay at home longer if we get that right. So that sort of question, as a research question as well as a care question, is a really important one.
We're doing a number of other improvements, particularly in our frailty pathway, and been looking at how we can support people to get home as early as possible. So your involvement and engagement, we're really keen to make sure patients and staff and carers can absolutely influence those changes. So I think through the route that Rachel's picked up, we'll make sure that those are also fed into those improvements. Thank you.
Okay. Sorry, good afternoon. I hope this is appropriate. I am registered blind. I have one leg, but I owe my life and everything to this hospital, and that's why I volunteer here twice a week. But there's just one issue, perhaps, and I hope it's the right forum, but I actually walked with Wisp, my guide dog, from here to the new CGC. And it is one heck of a walk. And I actually am now, yes, registered disabled, but I am physically able. I was actually running on my leg this morning and only had it amputated 7 months ago here. So, as I say, I have nothing but praise for this hospital. But surely, ladies and gentlemen, the idea of some transport from the hub, from here, to that unit, because people go there because they're ill. They don't go there for a photo session. They go there for an MRI scan, for an X-ray, because they are ill, they are frail. It's no good putting benches out for them to sit on. It's going to be pouring with rain, it's windy. You know, they need some sort of transport or facility from this part of the hospital to that unit. And I say no more because I know you all know what I'm actually talking about. But thank you for listening. And really, from Wisp and I, thank you for everything this hospital is doing and has done for me and everybody else. Bless you.
Thank you very much for having the courage to say that in front of us today. And I'm Chris, I'm the Chief Operating Officer. And today was the first day where I've positioned myself in our staff listening hub. And two other members of staff have raised the same issue with me today. So your thoughts are certainly not lost on us. And what we've got to do is find a way through it. I think all the things we've suggested thus far have met with resistance for various sensible reasons, but it isn't that we aren't going to do something. We just haven't quite landed on what the right way of managing it looks like just yet. But thank you very much for raising it with us today.
Thanks very much. Really interesting sort of presentation, and it was really good to speak to people outside, all the volunteers and all the work that's been done. But on Tuesday, at County Hall, we had David Roberts and Professor Andrei Stashison from Ukraine coming around, and I think I'd like to commend you on the work that you're doing with them and sharing that expertise you have here with a war-torn country, but also I think that collaboration and sharing is really important, not just when people are in extreme situation, but across the board. And I think that's one of the great things that's happening, that collaboration sharing. But thank you for everything you've done there as well.
So I've got the pleasure of going for dinner with him tonight after this, actually. But I've been involved in a few of those meetings already. I'd have to say, hearing firsthand their experiences from their hospital, it really does put life here in a completely different perspective. When you think about the numbers of seriously traumatised patients and amputees, lots of children amputees, and obviously that's even more complex than the fact that they need to have repeated resizing for their prostheses, etc., the amount of psychological trauma that they experience. So we are in very keen collaboration with them, both to support them, but they'll actually also help us. So we've got research developments that we're going ahead with, but we're also looking at potential clinical visits from our team. Obviously, as we move towards a major trauma centre here, they've got vast experience for very, very unfortunate reasons. So thank you for raising it. It is something that we definitely wish to continue with.
I think we're done. Do you want to close then, Mark? Yeah.
Please welcome back Interim Group Chair Mark Friend for the closing remarks.
So look, I want to thank you all for coming and talking. We've heard a taste of what's happening right now, and the innovation we've heard about today, fantastic. It's a taste of the future and fits with the 10-year plan. It's happening right now, it's happening here. And I think the wonderful thing is that the questions that were raised, say, around the virtual wards, what we heard back from our teams is they're really listening to patients. Our patients are co-creating these services with us because that's how they're going to work best. So we adapt and we reflect. And I think I thank you for your involvement and all for coming, and those online. But this is how we have to go forward to make the most of the opportunities we have, is to work together to shape that. And that's what we are committed to doing, both as a hospital and as a group. That's how we're going to take it. So thank you very much for coming. Thank you, everybody, and have a good evening.